otot kawa, tulang besi.
Tidak ada yang lebih membanggakan dengan menyebut diri kita bagian dari Universitas Aisyah. tepat 10 Maret 2016, Stikes Aisyah Yogyakarta berubah bentuk menjadi Universitas Aisyah. Bersatu, kita melanjutkan perjuangan mencerdaskan pemilik masa depan. Unisa, profesional Qur'ani.
Hai, ini Ahmad. Dan ini Aisyah. Mereka sedang kebingungan mencari kampus yang tepat di Yogyakarta. Jangan risau, ada kami di sini. Kami Unisa, Universitas Aisyah Yogyakarta. Kami merupakan sebuah kampus yang berwawasan kesehatan dan Islam berkemajuan. Di Unisa, kamu bisa memilih dari 3 fakultas yang ada, seperti Fakultas Ilmu Kesehatan, Fakultas Ekonomi, Ilmu Sosial dan Humaniora, serta Fakultas Sains dan Teknologi, dan kami juga memiliki jaringan kemitraan pasar kerja yang luas. Ide? Tunggu apa lagi? Daftarkan dirimu di Unisa, Profesional Qur'ani.
Ini bukan sekedar harapan. Ini bukan sekedar angan. Di sini, kamu tidak mengukir bayangan, namun membangun impian. Kami membawa sebuah nilai, berwawasan kesehatan, dan Islam berkemajuan. Unisa, Profesional Qur'ani.
Yogyakarta gains the predicate of the city of education, with peaceful environment, friendly people, and also affordable living costs. Yogyakarta has become a decent space to offer a better educational climate. Even with their distinctive cultural arts education, can bring many students from abroad to study art and culture in Yogyakarta. Aisyah Yogyakarta University performs a qualified professional education, has vision to become a distinguished college in the development of human resources and the science and technology based on values of Islam in order to fulfill the need of labor demand at the level of national, regional, even global, given education, research, and community survey based on values of Islam to enrich the life of a nation. Aisyah Yogyakarta is expected to score human resources with morals, insights, professionalism, and spirit of entrepreneurship to face the challenging era. It was first established as a midwife school and healthcare support level C school of PKU Muhammadiyah Yogyakarta Hospital in 1963 as the origin of Stikes Aisyah Yogyakarta establishment. Based on the final decision of National Education Minister, it was later developed into Sekolah Tinggi Ilmu Kesehatan or Stikes Aisyah Yogyakarta. Later on, by the way of the decree of Kemenristek Dikti number 109/KPT/1/2016, Stikes Aisyah Yogyakarta. As a form of consistency with the age more than half a century, Aisyah University Yogyakarta already has 3 faculties with 16 study programs. All 16 study programs have been accredited by BAN PT. Each of study programs is hoped to score well-qualified graduates at the level of national, regional, even global. The teaching method used is lecture, and for the theory, the approach of student-centered learning, tutorial, and e-learning. Aisyah University is also equipped with a laboratory, lab facilities, and a clinic for study programs in Faculty of Health Sciences. In collaboration with 88 institutions across Indonesia, Aisyah University is not just a place for field practice, but also a place for students' competence enhancement. Aisyah University has student organization as a medium for self-development and widening the horizon, also the personal integrity of the students. The aim of the student organization is to be the medium in developing the aptitudes and interests of the students as a provision to face the real life in the future. Every student of Aisyah University is given the chances to be participated actively in various activities of the student organization. As a form of community service to the society, in Aisyah University Yogyakarta, the implementation comes from the education and research which is held by academicians through counseling, posyandu, desa siaga sehat jiwa, and elderly health examination.
Alhamdulillahirrahmanirrahim atas ridho Allah Subhanahu wa Ta'ala dan juga atas ikhtiar sungguh-sungguh dari berbagai pihak, kami telah resmi menjadi Universitas Aisyah Yogyakarta. Universitas Aisyah Yogyakarta ini adalah wujud komitmen Aisyah dalam turut serta meningkatkan peran perempuan untuk mencerdaskan dan memajukan bangsa. UNISA akan terus berupaya untuk mengambil peluang-peluang strategis dalam pengembangan tridharma perguruan tinggi menuju universitas yang unggul dan berkemajuan.
Aisyah University Yogyakarta believes that the success of one institution is professionalism, which means that all educational activities must be managed with a good, visionary, well-planned management with high-quality standard. Aisyah University Yogyakarta also believes that by adopting and implementing the values of Al-Quran as a guidance to manage all activities in campus, the educational goal can be reached well for both terrestrial means and ukhrawi.
To create a creative and innovative generation, capable to contribute on empowerment and enlightenment, leading generation to the future that have the knowledge and insight based on progressive Islamic value.
Health policies for a bright future. Health communication is us.
Professional Qurani for more productive, happier, and valuable life.
Health information technology, empowering healthier life.
Life engineering today, brighter Islam tomorrow.
Health architecture for more livable and hospitable people.
Tak perlu menjadi hebat untuk memulai. Untuk berani memulai apa yang kamu impikan. Keluar dari zona nyaman dan jelajahi potensi yang kamu miliki. Saat kamu terhubung dengan orang lain, itu menjadi kekuatan untukmu. Saat kamu memilih menjadi kamu menjadi lebih dari yang sebelumnya, menjadi kekuatan baru bagimu. Di seluruh profesi, konsistensi adalah produk dari etos kerja kami. Kami membuka wawasan, pengetahuan, dan pengalaman yang mempersiapkan kamu untuk bertarung di dunia nyata. Di sini kami merubah harapan menjadi peluang untuk mencapai sebuah tujuan. Selama lebih dari 3 dekade, kami hadir mewujudkan cita-citamu sesuai dengan perkembangan zaman. Konsistensi kami di dunia pendidikan memberikan cara baru bagimu dalam memandang kehidupan. Mewujudkan cita-cita bersama kami adalah cara terbaik kami memprediksi masa depan dengan menciptakannya untukmu. Kami meyakini bahwa kunci dari kesuksesan adalah profesionalisme, standar kualitas yang tinggi, serta mengimplementasikan nilai-nilai yang terkandung dalam Quran sebagai pedoman yang dapat mewujudkan tujuan pendidikan yang bernilai duniawi dan ukhrawi. Di Unisa.
You don't have to be great to start, to dare to create your dreams. Get out of your comfort zone and explore your potential. When you connect with people, it strengthens you. When you choose to be Unisa, you become more than before, and that's your power. Across all professions, consistency is a result of our work ethic. We open insight, knowledge, and experience that prepare you to fight in the real world. Here, we turn expectations into opportunities to achieve a goal. For more than 3 decades, we are here to realize your dreams that follow era development. Our consistency in education provides a new way for you to view life. Realizing your plans with us is our way of predicting the future and creating it for you. The future belongs to those who prepare it today. The future gives rewards to those who move on. We believe that the keys to success are professionalism, high-quality standards, and the implementation of the values in the Quran as a guide that can realize educational goals that have worldly and hereafter values. Be Unisa.
Selamat datang di Universitas Aisyah Yogyakarta. Universitas Aisyah Yogyakarta atau yang kita kenal dengan Unisa Yogyakarta merupakan kampus yang berwawasan kesehatan yang berbasis nilai Islam berkemajuan. Unisa Yogyakarta memiliki dua kampus, kampus 1, dan saat ini saya berada di kampus terpadu Unisa Yogyakarta di Jalan Siliwangi atau Ring Road Barat nomor 63. Saat ini saya sedang berada di gedung garda depan Unisa Yogyakarta yang diberi nama Gedung Siti Walidah. Siti Walidah adalah pendiri Sopo Tresno pada tahun 1914 yang menjadi cikal bakal dari Aisyah. Di Gedung Siti Walidah menjadi pusat administratif. Selain itu, di halaman Unisa Yogyakarta juga memiliki halte bus loh. Halte ini memfasilitasi pegawai dan juga mahasiswa terkait transportasi dari kampus terpadu ke kampus 1 dan juga sebaliknya. Menjadi pintu masuk utama di Gedung Siti Walidah ini memiliki layanan terdepan seperti penerimaan mahasiswa baru, akademik, dan juga keuangan. Selain layanan akademik, Universitas Aisyah Yogyakarta juga memiliki layanan kesehatan. Seperti di belakang saya, terdapat klinik fisioterapi yang tentunya dapat diakses oleh masyarakat umum. Klinik ini juga menjadi penunjang pelajaran bagi mahasiswa dengan fasilitas yang lengkap, sehingga diharapkan nantinya para lulusan dapat menangani dan juga membantu pasien dalam dunia kerja. Unisa Yogyakarta memberikan privilege kesehatan kepada seluruh pegawai dan juga seluruh mahasiswa dengan membuka layanan klinik dana sehat Muhammadiyah. Di sini, seluruh pegawai dan mahasiswa dapat berkonsultasi dan juga periksa kesehatan yang juga akan dilayani oleh dokter. Dan kalau kamu sakit, nanti akan diberi obat loh, gratis. Halo dok. Dan sekarang kita sedang berada di lantai 4 Gedung Siti Walidah. Di depan saya ini terdapat Hall Siti Barorah Barit yang berkapasitas 300 orang dengan setting tempat teater, sehingga memberikan kesempatan untuk orang yang berada di belakang untuk bisa melihat ke depan dengan jelas. Di sini biasanya digunakan untuk
Hall of Siti Munjiah Baror. We would like express your gratitude to the Excellency to Second Vice Dean Faculty of Health, Universitas Aisyah Yogyakarta, Mrs. Suratini Sarjana Keperawatan, Magister Keperawatan Spesialis Komunitas. Honorable the Head of Bachelor of Nursing Program, Nursing Profession Program, Universitas Aisyah Yogyakarta, Mrs. Desti Nurma Gupita, Sarjana Keperawatan Nurse, Magister Keperawatan, Spesialis Keperawatan Jiwa. Honorable the Head of Magister Midwifery, Andari PhD. Honorable the Speaker, Professor Dr. M.Ed. Jok Hayer LMM. Honorable Dr. Opi. Honorable Lecturer and Staff of Universitas Aisyah Yogyakarta. Honorable ladies and gentlemen, the participants of lecture. First, let us praise our God because we can get here, who has given us health and happiness today. This day is a great honor for me, Dina Elisha Bania, to be here and welcome every age of you in this event. We present the lecture about current staff of management in hospital for cancer patient care. Before moving on to the next agenda, let me tell you the rundown of today's meeting. The first, opening ceremony. Second, Quran dissection. Welcoming speech by the second Vice Dean Faculty of Health, Universitas Aisyah Yogyakarta. Presentation by the speaker, discussion, presentation of appreciation certificate on senior version, closing. And well, let us the general studium by reciting Basmalah together. The next agenda is Quran dissection that will be recited by our student. Miss Mana Azurhub Dwi Ratna, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Ya ayyuhalladzina amanu idza qila lakum tafassahu Idza qila lakum tafassahu fil majalisi fafsahu yafsahillahu lakum wa idza qila suzu fasuzu yarfa'illahu Alladina amanu minkum walladina utul ilma darajat. Wallahu bima ta'maluna khabir. Sadaqallahul adzim. Dan artinya, wahai orang-orang yang beriman, apabila dikatakan kepadamu, berikanlah kelapangan di dalam majelis-majelis, maka lapangkanlah. Niscaya Allah akan memberi kelapangan untukmu. Dan apabila dikatakan, berdirilah kamu, maka berdirilah. Niscaya Allah akan mengangkat derajat orang-orang yang beriman di antaramu. Dan orang-orang yang diberi ilmu beberapa derajat. Dan Allah Maha teliti terhadap apa yang kamu kerjakan. Wassalamualaikum warahmatullahi wabarakatuh.
The next agenda is welcoming speech from the second Vice Dekan Faculty of Health, Universitas Aisyah Yogyakarta, and also will open all of the agenda today. Ladies and gentlemen, we would like to invite Mirsud Sarjana Keperawatan Magister Keperawatan Spesialis Komunitas to the stage. The stage is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Saya senang kalau melihat adik-adik semangat. Ya, I am glad because you very enjoy and comfort, cool of smiling. Okay. Okay, the Honorable of Prof. George York Hire, Chief Management Officer, Comprehensive Cancer Center of Hanover Medical School, Jerman. Welcome to University of Aisyah Yogyakarta. I will you enjoy and comfort in Yogyakarta. Okay. The Honorable Ibunda Dr. Upi, memanggilnya lebih pendek Dr. Upi selaku BPH dari Universitas Aisyah Yogyakarta dan sekaligus Ibu Direktur Rumah Sakit PKU yang saya hormati. Marilah kita panjatkan puji syukur kehadirat Allah Subhanahu wa Ta'ala yang telah memberikan rahmat, taufik dan hidayahnya kepada kita semua sehingga pada hari ini alhamdulillah kita bisa bertemu bersilaturahmi dan momen yang membahagiakan ketika bersama untuk update pengetahuan. Gitu ya. Tak lupa salawat dan salam senantiasa kita haturkan kepada junjungan kita Nabi Agung Muhammad Sallallahu Alaihi Wasallam beserta para sahabatnya. Amin ya Rabbal Alamin. Perkenankan saya pada kesempatan hari ini memohonkan pamit Bapak Dekan karena pada kesempatan hari ini beliau baru ada kegiatan di Bali sehingga saya diminta untuk mewakili beliau pada kesempatan hari ini. Tentunya fakultas sangat mendukung, very support in the activity of jadi kegiatan-kegiatan yang scientific in activities in Faculty of Science in University Aisyah Yogyakarta dan tentunya karena ini sangat sinergis dengan unggulan dari program studi keperawatan, the excellence of palliative care in nursing, dan ini merupakan program studi dengan excellent accreditation in Faculty of Nursing. Ya, jadi karena ini adalah prodi yang unggul yang kita gadang-gadang besok kemudian ini kan akan reakreditasi lagi kembali Ibu, ini juga unggul sehingga mari bersama kita upayakan dengan terus kita belajar kemudian memupuk ilmu pengetahuan dengan kegiatan-kegiatan ilmiah yang seperti ini. Apalagi pada hari ini adik-adik yang di belakang ngantuk mboten? Mboten. Semangat ya kehadiran Prof pada hari ini ya. Baik. Ya. Jadi saya berharap nanti monggo bisa banyak nanti pelayanan atau manajemen pelayanan untuk pasien-pasien yang mengalami cancer atau stadium paliatif yang ada di rumah sakit. Nah, silahkan kalau nanti mau in English lebih bagus gitu ya. in Indonesia juga nanti tidak apa-apa bisa kita terjemahkan bersama untuk kita sampaikan kepada beliau. Nah, kemudian saya berharap mudah-mudahan ini semakin meningkatkan pemahaman penjenengan semuanya, kemudian juga nanti harapannya bagaimana bisa mengintegrasikan pada semua mata kuliah yang sudah ditempuh oleh adik-adik semua. Ketika masuk di keperawatan anak, keperawatan medikal bedah, keperawatan maternitas, keperawatan gerontik, keperawatan keluarga, dan seterusnya, tentu nanti bisa diintegrasikan, lalu bagaimana bisa belajar bersama di sini. Saya berharap juga adik-adik kemudian punya gambaran. Kalau kita harus bersifat global, ya berwawasan global, artinya bahwa adik-adik tidak lagi berorientasi pada bagaimana pelayanan yang ada di Indonesia, tapi kita bisa harus melihat bagaimana dunia luar. Sehingga itu menjadi gambaran nyata saudara, syukur kemudian kalau Anda kemudian kepingin sekali Anda mau bekerja di sana. Nah tentunya hari ini Dr. Upi selaku beliau konten concern dalam bidang paliatif itu, monggo kita gunakan waktu seoptimal mungkin pada hari ini untuk bisa Anda benar-benar paham dan atas kegiatan pada hari ini. Tentunya Prodi sudah menyiapkan banyak hal Ibu, jadi ini alhamdulillah kegiatan-kegiatan kita yang kita lakukan dari running hari ke hari, kita banyak yang internasional yang kita hadirkan supaya untuk meningkatkan kapasitas mahasiswa dalam wawasan global gitu ya, untuk meningkatkan pemahaman itu semua. Mungkin itu saja yang bisa saya sampaikan, kurang lebihnya mohon maaf. Waktu kami haturkan dan saya mohon nanti Prof bisa berdiskusi panjang tentang palliative, discuss of palliative. Yes. Ya. Ya. Ya, terima kasih. Waktu kami haturkan kembali kepada pembawa acara. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih banyak Bu Suratini. The next agenda is the lecture. We have been waiting for the lecture and discussion session. Moving along, and I am pleased to introduce the guest speaker, Professor Dr. M.Ed. Yuak Hayer, LMM.
Selamat pagi. That's almost all I can tell you in Bahasa. So I have to talk to you in English, and I will try to be slow enough that all of you can understand everything. So first of all, I want to thank you for the invitation to present you here some of the experience that we have in Germany, to explain you what is important for the development in Indonesia. And so what could you learn from our experience, and what the first point, I don't know, maybe you have heard about these topics. This is WHO criteria for a good development of health. You probably know the Sustainable Development Goals. And here we have one goal that is related to good health. And so part of our profession is to really support the population that you have in your country as well as we do in our country. And these 5 criteria are actually very important if you are talking about healthcare. So what is available? How can we access the available structures? Is it affordable to the population? Can they pay for it? Is the provision that you are providing, is it acceptable for the population? And I will explain you a little bit, especially acceptability. What is a special question regarding acceptability? You have a lot of religious background in your country. We have a different religious background in our country. So we cannot just copy and paste what is successful in Germany will not entirely work here in your country. So we always have to look what is the lesson that you can learn from our experience, what we have to change regarding the development, and so that the population is accepting everything. And the last point, this is, of course, quality of care. I will use these parts here to analyze a little bit what makes good cancer care, what characterizes good cancer care. And as I learned today, you have a special interest in palliative care. So I will always try to get some connections. And palliative care is also related to this. What about cancer in Indonesia? Actually, if you take the situation today, cancer is demography. But in the next 10 years, the number of cancer cases will double in your country because of this demographic development. So cancer will become a very important part of, especially of your professional life. And so you have to deal with cancer in the future, and you have to deal with all stages of cancer in the future. And that's why palliative care has a lot to do with oncology, even in your country. And by looking here, where is Indonesia right now? Here you can see that the cancer incidence is still reasonable. This is, again, a demographic issue. Your population is still very young, but cancer is a disease above 50, actually above 60 years of age. And once your population will reach this age group, then you will have cancer cases. And that's why it's so important that you are trained for taking care of cancer. Oh, this is okay. And here you can see that cancer mortality rates are very important, but, and this is something that you can improve, we don't have numbers for Indonesia. It's very difficult to get official information. You don't have a cancer registry, for example, right now in Indonesia. So it's not really easy for your country to discuss about quality of care in cancer, because you don't know. And this is something where, that I really would suggest you at your generation try to develop something where you see what you are doing. So every time you should use a reflection of quality of care. And I will explain you why this is so important. I will explain you these topics using our experience in Germany. And this is actually what you can learn, that taking care on quality is really important in what you are doing. I already mentioned that acceptance is very important. Here I show you some acceptance problems that we have in Germany. And these are examples, and I used examples especially since most of you are women, and this is, as I learned, the woman organization. So I used an example that is related to women and cancer. Cervical is the most important in women here in your country because of lacking of prevention. In Germany, we have a prevention program. But here you can see that only half of the population is accepting this program. So only 50% of the women who are eligible for these things will really go to preventive programs. So they don't care. The other half doesn't care. The differences throughout the population are very large. It depends on age, it depends on education, and so we are not reaching our entire population with the prevention programs, and that's why our incidence on our cancer incidence is still higher than it should be. And the same problem is true here in Indonesia, even at a different level. So taking care and prevention, and that the population is accepting what you are providing, is very important. In Indonesia, you have for HPV, you have even a lower acceptance rate. It's less than 8% of the women are going to the visual inspection, less than 8%. And you have to improve this type of prevention to get a better cancer care. What are the reasons that the population, or in this case, that the women are not going to the prevention programs? These are German numbers. But first is that females are doing better than males, as always. And the second point here that you can see is that the acceptance of the prevention programs has to do with age. And the young population here, between around 40, the young population has a very low acceptance rate. And as older as they get, the more experience they gain, the acceptance rate slowly increases. So we have to educate the population to accept what is important. And this has to do with vaccination programs. This has to do with cancer prevention programs and others. So you need to address these type of questions that the population have to really get high effects in prevention. What are other points that we need to take care for this type of acceptance topics? In our country, we have a language problem. We got a lot of migration into our country from all over the world. And many of the migrants do not speak German, so they do not understand what we are talking about. Then we have the cultural and religious problem I mentioned already. So most of the migrants, for example, have a Muslimic background. So in Germany, our major background is Christian. So we have different values. We have a different attitude to treat. And so we have to adapt our educational programs, our way to handle these things according to the background of the population. And unfortunately, most of the migrants are not using our prevention programs. Education, I mentioned already, but also the social environment and the understanding of the disease is very important. Sticking with the cervical cancer prevention, social environment means that the women need to explain and need to discuss with their husbands what happens if they have something, especially in the reproductive tract. This is a topic that is not easy to talk about in a family. So the social environment is important. The other one could be if you have some religious restraints. So also the religious leaders need to support this type of prevention or vaccination or something like this. So this is also very important that you can get a high acceptance of what we want to produce. And this is only one example. Very much the same data I could show you for palliative care. So palliative care is also a question of acceptance, of cultural environment. Who is doing what? Where do the patients want to be in the last phase of their life? Do they want to have hospital care? Better would be to be treated at home, but then you need to provide a good service for home care. So this is something that is really important. Acceptance is something that in the Western world, for a long time, we actually didn't care. Now we learned that acceptance of the care that we provide has a real strong effect. Another point that is also very important for cancer care, and this has especially to do with your country, but it's not limited to countries like yours. This is the financial issue. And usually regarding affordability, we have in mind, of course, what do I have to pay out of pocket treatment for payment for the treatment. So how much costs do we have for the drugs? How much cost do we have for the hospital? Is it covered by the BPJS? But there are also other topics, and they are very important. Financial burden for cancer has to do with loss of income. So if, for example, a woman who was taking care on the family, if she is losing the job because of cancer, the family income is going down. In addition, you have travel costs. You have to pay, for example, for accommodation, for additional accommodation, all these things. So there are a lot of different parts of affordability. It's not just treatment costs. And this affordability is also very important. This has to do in your country, especially remote areas. So remote areas means a lot of travel. But who is paying for these things? How can the people reach the next hospital that can do cancer care? So this has to do with affordability. And this is also something that the entire structure, the entire development of a healthcare system needs to address. What is the burden of financial topics if you have cancer in your family? And this is not only true for yourself, this also affects the family. If someone in the family is cancer, especially if you have childhood cancer. In childhood cancer, this is even worse because the entire family takes care on the children. The entire family has to deal with it. So the loss of income and the additional burden can go up to 50, 60, 70%. And this is just for the family-based caregiving. So this is not related directly to the cost. So additional cost of 20, 25%, additional costs for cancer care in children has to be covered by the family. This is not covered by the government. This is not covered by the BPJS. So the family has to take care of this burden. So it's also very important that if you have someone who is has to deal with cancer in any case, and in palliative care, it's even more important, then you should ask them, how can you afford everything? How can we adapt what we are doing to the options that you have in your family? So this is one example to illustrate you how important these things is. This is the drop of income if you have cancer care in Germany. So even after 4 years of diagnosis, it's not just year one. Even after 4 years of cancer diagnosis, the reduction reaches almost 50%. So an almost 50% less income. Imagine in your country, what does it mean to many families? So it's a real important point. Oops. So what are the determinants of this financial risk? This is also something that you can find in your country as well as we have it in our country. So, of course, comorbidities are very important. The educational level is important. If you have high income because of good education, it's easier to handle. This is related to the employed, and unfortunately, women suffer more than men. So why is it so important again? So the question is why I'm talking about these things to you here in Indonesia. And I had the privilege together with Dr. Upi that we could analyze the situation here in Indonesia. And I can show you some results and explain you some results from the BPJS. So we know how the situation is here, and I will share some of this information with you. So I already explained you, this is a projection of the importance of cancer care. So here you can see that in the next 10 years, the increase, as I said, cancer cases will double, and after that it will go even higher. So what is important? If you look here, what is important? The availability of general practitioners is one of the key factors that you have right now in Indonesia for cancer care, for palliative care. So you need good coverage with general practitioners. The second one, this is important to the specialized care. For cancer care, the number of level A and level B hospitals in your country is still too low. You have a very unique situation here in Yorkshire. I will explain you in a few minutes. You have a very unique situation here, but if you look throughout the country, level A and level B is very low. Sorry. Yeah. The next point is that the access to the levels and the structures of cancer care are still to be improved, I would say. Right now, you have differences between in the population. If the patients are covered by PBI, so the poor people, they use different ways compared to the PBI patients. So, but this makes a system ineffective. So it costs more if patients are not using the primary care as a selection point. If they are going directly to level B hospital, for example, this makes the treatment ineffective, because then the level B hospitals have to deal with simple problems, and simple problems can be solved by level C or D. So the selection of the patient is very important, that you will guide them to the right point in the healthcare system. And you will be the one who are responsible for guidance. And this is also true, again, for palliative care. So if you are responsible in somewhere, for example, in Papua, if you will be responsible there, you really have to think which patients need specialized care and what type of care you can provide in the structure that you have. And to avoid additional costs regarding transportation, to avoid costs because level B is actually not required. So referral system, this is how it is called internationally. The referral system should work, and then the resources can be used in a better way, and the development of the healthcare, of the quality of care, will be improved just by doing a good management. And the last point, this has to do with the acceptance that I explained, is patient-related barriers for using the healthcare structures. Here you can see how important cancer care is in your population, especially for the woman. Breast cancer and cervical cancer accounts for about half of everything. So the female reproductive tract is very important, and both types of cancer actually are subject to prevention or early detection. So you can use, instead of treating advanced cancer, you can use, and this is better for the patients, you are more effective in what you are doing if you can use prevention and early detection. This has much higher effects than very sophisticated surgery or drug treatment. So, and again, in both cancer cases, these type of investigations, these type of examinations for the patients is available. So convince the patients, convince the woman to accept these type of programs. They should go to early detection. So they should do self-examination of the breast. They should use, right now it's VIA, maybe later we have types of prevention programs. But you are the one who should really talk to them and convince them this is something that is important and this can prevent cancer. And then you are not suffering. And explain them that this has nothing to do, that the woman is guilty for anything. This is nature, is not guilty, it's nature. And convince also the husbands that the women have not done anything bad, because this is a natural development. And this is your task, not mine. I cannot help you, I can explain you. Yeah. So let's go back to this nice map and look again to these type of criteria. The next one. Yeah. Very important is that the patients, next. Yeah. Very important is that you address the difference, the discrepancy between that the patient is seeking healthcare and that the access to healthcare is sometimes a problem. So we call this vulnerability. Vulnerability is the next, please. Yeah, vulnerability can have different reasons. Next. Yeah. So to accept everything has to do with the emotion. So cancer is life-threatening. Of course, many people have really fear to have been diagnosed with cancer. But if you are diagnosed early, the better the treatment is. Vulnerability has also to do with political decisions and resource management. So the poor people, the far remote areas are less supported. So this vulnerability has to be addressed. They have more difficulties to get good health care. And so this should be avoided or at least minimized. Next. And this is something that probably nobody here in the room was thinking about these things. We have an individual perspective regarding all these things. So all of you, everyone has a unique perspective, and they see the problems in a different way. And this is different from the public perspective. Public perspective means to get the best effects in the entire healthcare system. And if you are talking to a single patient, then of course the single patient in this case is the most important person right now. But if you are talking about the public perspective, you have to make priorities. You have to decide where are the level A hospitals located. So there's always a fight between the public perspective and the individual perspective. And as the better you can understand what are the public perspectives, what are the reasons to do to distribute the resources, the better you can arrange yourself. If you understand the referral system and why it is, then you can understand what you want, how you to manage the care. The next one. I already mentioned that you have a very special situation here in Yorkshire. These are the data from the BPJS, and we were looking where are the patients treated. And then you can divide into 3 different types of provinces. So we analyzed in each province, how is the treatment organized in Indonesia? And you can see 2 areas. One is the Jakarta region and one is the Jogja region. And what is special here? The specialty here in this region is that in Jogja, the patients from the entire country are treated. So you have, we call it treatment migration. So many patients are coming from outside of the province of Yogyakarta to be treated here in Jogja. This is a very special situation. It's only comparable to Jakarta. So you have a net income. And in all other provinces, more patients are going out for treatment than coming in. So at Jogja, you have a special situation for cancer care. Many patients, much more patients than you have in your own population here in your province are coming for treatment. And if you are thinking about palliative care, this means that you have long distances. They have to travel a lot for treatment. If this is still the case for palliative care, these data are not related directly to palliative care. This is oncology in general. But this means that in Jogja, you have to think even more about how can you manage palliative care in a distant region. Patients from Papua are coming here to Jogja. We can see this in our data. The other topics is here in this map is, what about here? You have very remote areas, and compared to the population, so the population rate here is very low. And compared to the population, you actually have above average number of nurses and physicians. But now accessibility is a problem. If you have 50 kilometers in the rainforest, this could be really far away. And so these provinces need other topics compared to here. Here you have actually relatively small distances. Also sometimes it's a traffic problem, and you have rainforest and mountain areas as well. But you have to, if you manage cancer care and if you manage palliative care, you really have to think about where are you. So you cannot just copy and paste. In Jogja, palliative care management is different compared to, again, Papua as an example, or Kalimantan, or where you are. Next one. This is again a type of analysis, but this is not related to the population density. This is related to the availability of healthcare resources. And now you can see that we have different distribution. You have high resources here compared to the population in Jakarta and in Jogja. Here, population density is the issue. So I don't want to go too much into detail, but you can see that you can take different type of perspectives to analyze the cancer care and then to draw conclusions how to arrange cancer care, oncology care, or palliative care. Very similar approaches you can do for all other things. So this is just an example how to organize healthcare. The next one. And this is just a little summary that this is not one-to-one connection. So we have provinces where you have a high population coverage, but also a high problem with high rate of poor population. You have remote populations with low resources and a low poor population. So you can address these things, and you can make it very complicated to analyze these things. This is something that you need to understand if you are responsible for managing, not the single patients, for managing the cancer care. Next one. Why is it so important for Indonesia? I mentioned briefly already that you have differences. In the population between PBI and non-PBI members. So these are the differences. These are the PBI members. These are the non-PBI members. And here you can see in all provinces, in all different types of provinces, you can see that the non-PBI members, so the more the people that can afford more treatment, they are using the healthcare system at a higher rate compared to the PBI1. The PBI1 cannot afford everything. And they are not accepting the problem, the healthcare, for different reasons. Next one. This is a little summary for these things. So in all categories, you can see it everywhere, that you have differences between the poor population and the non-poor population. So you need to address it in a different way. Next one. These are the migration rates I mentioned already. If you look at the provinces, here are the migration rates, and you can see from where the cancer patients are coming. So you have a hotspot here in Kalimantan, you have Banda Aceh, and you see that the cancer patients are not going out in Jogja. Next one. This is the same analysis, but just vice versa. Where are the patients going? And you might miss now Kalimantan and Sumatra and so on. Patients are not going there. They are coming from there. So you have no migration into these areas, but you have migration out of it. And as I mentioned, all patients who are traveling are either going to Jakarta or to Jogja. And this explains the very special situation that you have here and the responsibility, this very special responsibility that you in your region have to face. Next one. What are the reasons? This you can also analyze. What are the reasons about for this type of traveling? So we could look which patient groups are really doing this type of migration. And then again, you can find some pattern that demography plays a role, availability of the human resources is important. This is just to explain you that this can be analyzed. You don't need to reproduce all these things, but this can be analyzed if you look at the data, and that's why having good data is very important, especially for cancer care. You need to understand for management issues what you are doing and who is doing what. Next one. We can skip this. Yeah. So taking the message together, for cancer management and for palliative care management, what is the most important part? That you organize how to treat the right patient at the right time in the right service structure. So this is actually what referral means. That you have to decide which patients should be treated where. Who is responsible? Who can take the responsibility? Which structure is available and which structure you can use? And then you can decide especially who is doing what at which time. So this is not a one-time decision. So you always have to question if is the situation still the same if you have to change. So over time, the responsibility will change. So if you have a palliative care situation, in early palliative care, the situation is quite different compared to end-stage palliative care. So the time dynamic is very important. So always question yourself if the decisions that you have made before is still valid for the situations that you are facing now. Next one. The last point that I want to show you is what are we doing? How are we facing this situation in Germany? And maybe you can learn some of our experiences. We have experience, one please. We have experience in Germany next for about 100, almost 50 years, 140, 150 years of social coverage. You have right now experience of 8 years of coverage. So my message actually is you can learn a little bit and maybe you can avoid at least some of the mistakes that we are making in Germany. And that's why I want to explain you how we deal with these things. About 15 years ago, so in 2008, our government, together with our professional organizations, developed the so-called National Cancer Plan. And this National Cancer Plan actually contained a standardized certification program. So we had some developments before, but here in the National Cancer Plan, it was formulated that the certification, so a quality management program for cancer care, will be rolled out for the entire types of cancer. And this program now covers 95% or even more, 95% of cancer care in Germany. So all of the cancer entities, all of the entire chain of delivery, so from prevention up to palliative care, is now included in our certification program. This does not mean that all the providers, that all the hospitals already are working according to these things. But we try to push everything and to really roll out this type of certification program throughout the country, that all the patients are treated under these conditions. Very important is that all the areas are included, so early detection, diagnostic, therapy, and palliative care. Next one. How can we organize these things? So we have 3 different levels. This is a little bit comparable to what you have here for the level DCBA hospitals, a little bit. We have organ cancer centers. They are treating specific entities: breast cancer center, gynecology cancer center, colorectal cancer center. And then we have the oncology centers. So oncology centers means that these are the larger hospitals. They are covering more entities. And so they have a certain number of organ cancer centers as part of them. So they are responsible for the overall treatment. And last but not least, we call it the comprehensive cancer centers. And these are usually the university hospitals. They are also doing research and education. But, and this is very important, we do not have any differences regarding the requirement. So the requirements for an organ cancer center in a hospital, in a smaller hospital that is in our remote areas, are the same as we have it in the capital of our state. So the quality requirements we implemented are the same for the entire country. Next one. Yeah. The quality management is organized according to a very general principle. Maybe some of you heard about the so-called PDCA cycle. So PDCA is actually coming from the industry, I think 50 years ago or so, or even more. So PDCA means that you always check what you are doing, and you always develop your quality program. And this is a circle. So we plan what we want to do. Then we realize these things. And important steps are now, we check what we did. And if we have some differences, then we take new actions. And these new actions are planned, and then we have the cycle again. And this in cancer care, this is every year we are doing these things. Every year we have to report to our to external advisors how we are doing, and they give us advice, which is a lot of work. Sometimes it's a lot of headache because I always have to look if all my cancer care is working. And this is also done at the national level. So we have evidence-based guidelines. I know that in Indonesia, you have also guidelines who are released by the Ministry of Health. And these guidelines in Germany are under control. So these guidelines in Germany contain quality indicators. So for all entities, we know how to measure the quality. And these indicators are used for the entire country to further develop the certification program. And then the certification, we are using it by, for example, cancer registries. And then we look if the indicators and if the guidelines need to be developed for the next step. So we have this PDA cycle everywhere, at the national level, at our center level, and actually you can use it even at your personal level. Always ask yourself if you achieved what you are supposed to be, and then take your action. Next one. What is the certification about? Certification means we have to report about the infrastructure, about the availability and qualification of our staff, about our cancer care processes, how we organize everything. And this is, of course, very important and actually the most important part, what is the outcome of for our patients? So all these things are integrated in the certification requirements. That's the next. And the control is done, we call it the internal audits. So this is what we are organizing by ourselves. So you know that I am the head of one of the comprehensive cancer centers. So with my team, I look to all our organ cancer centers. We give them advice. We look at the numbers and see if they are working well. And then we can PDCA, then we can draw conclusions together and see how we can support the development that they achieve the key indicators. We have a joint quality management system. So we provide a lot of standard operating procedures for all our staff. So we have written down what is the optimal way to treat. And these SOPs are very helpful, especially for the younger ones, because then if you are not very experienced, oh, I'm not sure, I don't need to ask the head of the department, because sometimes it's a little bit difficult and I don't know. So then he knows I know. Very easy. Here is the SOP. Just you know where it is. Look at it. And then I know how to treat. Much easier for the younger ones and even for the experienced ones. Sometimes we have situations where they don't know. They can also look at these things. If you are doing things not very often, sometimes it's not really clear. And for our quality management, the directors of the hospitals, they don't care about quality management. So they have to look, here it is written, you have to organize it. We agreed, all of us, we agreed to do these things. So please arrange it like this. So it's a tool that helps you to organize everything. Oh, this is actually external, sorry. This is external audits. So we get, every year we get auditors from external hospitals. So they are coming, looking at our processes, looking at our reporting system and give us advice. They provide a written report. And then you can see here, this is the result right now. This is the very current situation for the so-called oncology center. So for the big one. And you can see we have some areas that are pretty well covered, and we have remote areas. It's a different dimension compared to Indonesia, but we have remote areas. Look at here. Look at here. Look at here. There's not really an oncology center. So also the coverage in Germany is something that we have to face. So our center is located, just to let you know, this is our dot here. And so we have to take care on this region and on this region. This is our responsibility as a comprehensive cancer center. We have to think about our region, not just our center. We have to think about our region. So this is part of the task of our national cancer plan. Next one. The last point in this regard is actually what are actually comprehensive cancer centers? This is a little bit comparable with your national cancer centers. You have DAMAIs in oncology, you have others for other entities. So our comprehensive cancer centers are working at the national level, and we have a lot of tasks. It's not just the clinical care. We have to do research. We have to do clinical trials. We have to do outcome research. So this is a task that we also are subject to evaluation. We have to organize, I have shown you on the map, we have to organize our regional network. We have to organize what we call the community outreach, which means we have to educate the population. We have to educate nurses in other hospitals. And last but not least, this is what we call the multidisciplinary care. We have to organize how nurses are interacting with physicians, how palliative care is organized between patient service and inpatient service. So this is everything is responsibility of our center to look at these things, to look if it is working, and to try, then we try, if something is not really working, we try to improve it. Next one. This is to confuse you a little bit. You don't need to read everything. Such a system, and that the responsibilities are really taking a lot of effort to do these things. So all these little areas here are our areas of action, and to make it even more complicated, the next one. These are all our activities that we are doing. So we organize tumor boards, we organize molecular diagnostics, we organize, we call it an Onco Academy for education. We organize other educational patient-related events, and so on and so on. So I have a large team of people who are organizing everything. This is something, and this is probably, at least for a longer time, the difference between a country like yours, because you don't have the resources to do all these things. But in Germany, we can afford these things. But at least you should target parts of it. So talk to the different professions, especially the interaction between the professions. And this is mentioned here. Somewhere here, oncology nursing, here it is. Oncology nursing, interaction, in multi-professional treatment, interprofessional activities, joint tumor boards. So these are things that really improve the treatment, because then all participants in the treatment understand each other. And this gives a very good effect on the management. Next one. Cancer care, and this comes to, especially to the palliative care questions that you have. Cancer care is not just immediate treatment of the oncology problems. Cancer care also means that we have to deal with long-term problems. We have to deal with rehabilitation, and of course we try to do it in research. What is the long-term outcome? And long-term outcome also, unfortunately, means palliative care. And part of the survivorship program is, of course, that not all of the patients are surviving. We increase the survival rates a lot, but still we are facing non-survivors. And then palliative care needs to be part of oncology management. Next one. What I would really suggest you as a young generation and the entire country, that you, from the beginning of the cancer development, you should listen to the patients. What does it mean? And this is a lesson that we learned in the last few years. We have to listen more to the patients. This does not mean the individual interaction, of course, as physicians or as nurses. There is a direct interaction. You listen to your patient if the patient is sitting in front of you, of course. This is not what I mean. We listen now better to the patients to understand their perspective. And now remember, I have shown you the different perspectives. Perspective means that you have to understand what is important for them. Overall survival, as we are using it in clinical trials, sometimes it is not really important. I will explain you what I mean. For a young woman who has 2 or 3 young children, and if she is getting breast cancer, overall survival is not the first priority because she has social responsibility. She is asking, how can I treat, how can I get my children if that they are adjusted in their environment? The overall survival is only one part of it. For this woman, it's very important to be available to take care of the social responsibilities. Going to the other end, take an older man with prostate cancer, 80 or 85 of age. He doesn't care about overall survival. For him, it is not important to have 6 months more or not. For him, it is important that the symptoms, that the quality of life is the best that he can get for the time that he still has to live. And that's why our clinical trials, the endpoint of our clinical trials, our evidence is sometimes not the best one. Because as physicians, we are always proud, okay, we improved the overall survival by 6 months with a new treatment. That's great. But for the patients, it's not what they want. So it's important for you to listen. What is the patient perspective? What is what they really want to have? Palliative care. Listen to the patients. What do they want to have? Is it quality of life? Is it they still need few months because the children need to go to school or whatever? So you have really a question about their perspective. And to go even further, you can ask them to participate in the research. This is what we just implement. We include our patient representatives in our research teams so that we always ask them, is our research plan comfortable to your perspective? So is it equivalent or do you have other points to address? So my message to you is listen to the patients, understand the objective, and then you can make medicine. Next one. Yeah. One example, and especially I heard that some of you are working in the nursing area. So one example to improve this type of care is to get especially in the nursing programs. In Germany, we have different type of specialization. And here I just mentioned one of it. So we have breast nurses and oncology nurses. And these oncology and breast cancer nurses get special training that they can do a better interaction with the physicians, that there is a better bridge between the physicians and the nursing. So they are specially trained for all the tasks that are related to oncology. So the breast care nurses, they know how to deal with psycho-oncology problems. So they are trained in palliative care. So oncology nurses are trained in assisting in chemotherapy or something like this. So these are programs that we have in place since many years. And right now, and this is a very good message, right now we are trying to develop such type of programs here in Indonesia as well. And we will start here in Jogja. Next one. The next one is actually time for questions. I hope that I could deliver you some of the messages and that you understand that care is also important in your development, and you as a young generation have a really great duty to do. Thank you very much for your attention.
Okay, vielen Dank for the information, good information for the student or the student in Universitas Aisyah Yogyakarta. Okay, the next discussion session for student and have a slide order try fragen for you. Okay, okay. Adik-adik semua, silahkan ada yang mau bertanya, angkat tangan dan silahkan menyebutkan nama lengkap ya.
Yes. First of all, my name is Akila. I'm a second semester of international nursing program in UNISA. Okay. You say that in the future, maybe in the next 10 years, cancer cases will increase double and maybe higher, right? And in Indonesia, the most population is a young generation. And we, as a young generation, is the successor of the country in the future. And in the PowerPoint, it said that if someone have a cancer, they have a chance to lose their job and maybe their income. So as a future nurse, also health worker, and as a part of young generation, what can we do as the prevention cancer care? And maybe any lifestyle or any habits can give higher risk to become cancer. Because this is very important if the majority of young generation are sick. So who can take care of the other generation, like the older generation, our parents, and maybe another man, like the, so our parents is also have their support to us to have a higher quality of life. So thank you.
Thank you very much for this very important question, which addresses actually the major role that you here as young generation have in Indonesia. From my perspective, the most important role that you have is, besides, of course, taking care of the patients, educate the population. And especially if you are a nurse, you have a very special role in doing these things. If you explain to the population that is living around your location, you are responsible for a population. And if you are taking this responsibility and educate them, what is a good health behavior? How can they do the prevention programs to reduce their fears, and increase the acceptance? Coming back to the one example where we are really involved right now, convince all the women and their husbands that early detection and prevention programs for cervical cancer is preventing cancer, is improving health, and this is a responsibility that I cannot do and even the cancer centers cannot do. They are far away. So you have to educate the population for acceptance, for healthy behavior. This is the most important, and this will save more lives that you can do with your treatment. So this is one responsibility that especially the young generation in your country has. The second one, of course, I would say it's a kind of payback that you are asking for. How can I pay back the efforts that the parent generation spent? This has also to do with actually it's a healthcare management. So if you can guide them in the system, the best way to use the system is using the primary access. Look what I really have to avoid financial problems. So guide them through the system, explain them. The first step would be primary care, then the primary care can make the right decisions. I know that sometimes the quality of primary care has to be improved, of course, I know this. But guiding the patients through the system will the system make more efficient. And then the entire population will have benefit from a more efficient program. Besides organization, of course, palliative care is a very good example. So guiding your patients through the system is that you can organize the best palliative care they can get. You can treat them. This is the individual responsibility, but you are asking for the public view, public perspective. So guidance of the patients in the system is the public perspective.
Oke, ada lagi yang mau ingin bertanya, angkat tangan? Oke.
Assalamualaikum warahmatullahi wabarakatuh. Okay, first, thank you so much for your presentation. Your presentation is really great. And I want to ask something. As we know that one of the cause of cancer is a chemical substance, right? Yes. Currently, human life with many chemicals that are used and enter the body, such as soap, shampoo, skincare, drugs, medicine, etc. Moreover, nowadays skincare is widely used by many people around the world, like sunscreen and extra. Especially, how do we avoid cancer in this era? Are there any substance that cannot be combined in skincare, soap, shampoo, extra, and which can cause cancer cells to become active and cause? And the last question is,
Let me answer the one, and then you can take the second one.
Yeah.
Because the first one is very difficult.
Thank you.
The most important environmental factors. The most important environmental factors that you have here in Indonesia is smoking. Smoking, of course, has a lot of chemicals, but smoking is increasing. The rate of smokers in Indonesia is rising, especially rising in females. So addressing smoking is the most important one. The second environmental factor is, and I'm coming back to the cervical cancer program, there are some viruses in the environment, and viruses, they can cause cancer. So viral infections have a huge impact, and getting vaccinated against these viruses is another way of prevention. Early detection based on viruses is a way. And now it's getting difficult. We know that there are a number of chemicals that are related to cancer, but only a relatively small number of these chemicals are really directly causing cancer. We know some of them, but the usual environment that you have here, of course, there are some relationships, but it's very difficult to analyze it, and they're only a piece of the development, usually a small piece of development. So discussing chemical pollution is important, of course, I will not deny it, but you should not focus on chemical pollution in your discussion with cancer. You have much more problems with tobacco, with other infections, with acceptance of early detection. So these are the points that you really should focus on. And small amounts of chemicals in your environment, yeah, of course, I will not deny, but the priority should be less. And now you can come to the second question.
Tadi ada pertanyaan kedua ya? Oke.
Thank you for the first answer. And the second question is, how has technology developed in Germany in early cancer detection over time, and how and is there online care in Germany for the cancer?
I did not understand. Maybe you can ask Upi. Upi, can you assist in translating? Upi, can you assist in translating? No, no, she was asking.
Terapi di Jerman.
So telemedicine. Yeah, yeah. Yeah. Especially during the pandemic, we made a huge development, but we started before. In cancer, we have actually 3 areas right now. The most important one is that we organize our interdisciplinary tumor boards. Now we organize in a way that external participants can take part. So we have a video system which is approved by data protection. So we have a video system. It's not Zoom. So and this is being used by our tumor boards. So all cases, every cancer case is discussed in our tumor board, and our external partners can participate online in this discussion. They can bring their own cases, demonstrate them online, and so we will discuss the treatment, the further treatment all together, and they will get their feedback. This is part one. The second one is second opinion. So the physicians can send us the documents and can ask us, what would you do in our case? So we try to discuss this in tumor boards, but sometimes it's not working. Or the patients themselves can come to us, can send us everything, and we are just working on an online system where the patients can also address these questions. So there is a type of web-based interaction. So this is the second part, and the third one is especially during pandemic. We used video systems, for example, for follow-up of patients. So they were contacted by our physicians or sometimes by the nurses, and they were asked, what is your situation? Do you have any side effects? And then they have a list of questions that they address by video system. And if everything is fine, please stay at home, next call next week. And then the trained nurses or the physicians, if the patient reports something special, then they can decide, okay, this is something, needs a more intensive treatment. Please come to our center and we can treat you. So it's a kind of counseling, but for the patients themselves. And actually this system is what we suggested your government, that you establish a kind of video counseling in the remote areas. In Puskesmas, where no physician is available, or even if you have a general practitioner, sometimes he doesn't know how to decide. And then he can call someone in a specialized center by video system, by telemedicine, and they can interact and discuss what is the case, what is the best way, how the patient can be treated. And then we avoid inefficient referral system. We avoid inefficient referrals. So this is actually part 3. And one other is there are some additional technical solutions for radiology. So physicians or patients can upload imaging data, and then our radiologists can look at these things. So there are some feedback systems. So this is the typical telemedicine, the long-term telemedicine approach. But the new developments are the tumor boards, so the case discussions and the interaction with the patients via online. We are using similar systems, for example, for palliative care. We have specialized palliative care teams, and these teams are they are doing home care. So they go to the patients in their own environment, and these are usually nurses. and then the nurse is looking, how is the situation, how is it going with the patient, and something is not appropriate. They just usually they have a tablet or a little computer, and then they can contact the palliative care physician, and they can ask, is everything okay? They can provide some diagnostic data via the system. So it's also a type of counseling. But we will not treat only counseling and patients. If you have to treat patients, they have to come. If you have a specialist there and they ask for counseling, then of course they can take the treatment. But we will not replace treatment by online situations.
Okay, the next question. Ada yang myself. I'm Deci Ramanda Putri, nursing of student in Universitas Asia Yogyakarta. I want to ask to you how to highlight the palliative care in breast cancer for patients in final stage.
In primary healthcare?
In
in final stage. Our breast care nurses are usually involved mainly in primary treatment, but we have specialized nurses for palliative care. So the breast care nurses are taking care of post-operative situation, chemotherapy, hair replacement, and so on. And if you have final stage situation, then they hand over the specialized care to the palliative care nurses. They are specialized treatment, especially trained for final stage situation, for mucositis, for pain management, and all these things. So they have a very special education, and this is also a type of specialization in nursing. So nobody expects from a nurse that she can do everything. The same situation for a physician. I have no idea about gynecology or about cardiac problems. So no can expect that you know everything. So that's why we do the specialization. So breast care nurses for just for their special problems, oncology nurses for chemotherapy, palliative care nurses and pain nurses for end-stage treatment. So this is a type of specialization for nursing that at least in the, not even in the long run, in the middle run, you should look here in Indonesia how to specialize nurses that you can take care on the special situation.
Thank you, sir. Oke, tepuk tangannya dong. Selanjutnya ada yang saya lewat mana ya?
Assalamualaikum warahmatullahi wabarakatuh. First, I would like to introduce myself. My name is Muhammad Arman. I am from International Nursing Program. I have one question. What are some for communicating complex medical information to cancer patient and family?
Oh, also very difficult question. I could give another presentation. We are using many different types of communication. One type of communication, of course, is personal communication between patient and physician or patient. We young generations, the young fellows, are specifically trained for communication. So part of our education system is communication training. So we call it teaching hospitals, but these are not with patients, but we have actors there. So they can really train. They get feedback how they communicate. So this is one point. The second one is that we provide a lot of material that they can use. And this material is developed with specialists in communication. so that where it's an easy to read language, so that the patients can understand in their own words. So we avoid all the special wordings from the physicians or something like this. So we call it easy to read information, which is better understandable for patients. The third way of doing these things is always providing new information. For example, on the website, we are doing podcasts, we provide newsletters and all these things, so that interested patients always can get updated. What are new developments that they can follow up, and step by step they learn a little bit more about understanding their disease. And the last example that I want to explain you is actually why are we here right now. Right now, we have our team, two members of our team are at Yamada and in other areas here in Yorkshire, and they are producing educational films. You will see them probably by the end of the year. You can use these films, and they are also made by specialists, by communication specialists, and we will explain again in an easy to understand language. We explain these all these topics. This is related to cervical cancer prevention, and there is one major point that you have to have in mind. Your communication needs to be adapted to the people you are talking to. So you have to use different type of communication if you are talking to a patient compared, for example, to their social environment. So the husbands, staying with this example, if we explain a woman what is HPV testing in this case, what does it mean? The woman has other questions compared to her husband. So we produce also a film that is specifically addressing husbands. We are producing a third film. This is addressing the cadres, the religious environment. We are producing a fourth film. This is addressing the nurses, that they understand how to explain the topic to the patients. And so this is how you should organize your communication. Always keep in mind, what is actually my target group, to whom you are talking. And then how is the way that they understand what I want to deliver as a message. And so this reflection is very important. This has to do with acceptance and with cultural adaptation of what you are doing. So you cannot use the same words for everyone. So adapt and question, what is the educational level? What is the knowledge about cancer? So ask them, what do you know already? And then you can explain. What are your fears? Then you can address the fears. And then you understand everything. And the last point that I want to make, sometimes, only few patients, but sometimes they don't want to know anything. They just ignore anything. And it's very difficult for us to accept these things, but sometimes we have to. And then, which is not that rarely done, the patients say, I don't want to know anything, just treat me. I don't care, just treat me and leave me alone. Difficult to understand. Always we want to explain, this is our behavior. But in this case, you can accept, but maybe after a few weeks, ask again. Are you still in the same way that I should not explain? And then, so it's time by time. So it's not a one-time decision. Always ask, what do you understand? What do you want to know? And so this is a good way to communicate and train this here in your university environment, or even if you have someone in your background that they can just look at you. How did I communicate? Ask your colleague. Do you think that my patient understood what I want to deliver? And then they can give you a feedback, which is very important. They can just look, okay, the interaction was fine, or they didn't understand anything. So then you can adapt your communication.
Okay, thank you, Arman. And the last question.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Excuse me, sir. My name is Kinata Siarosi. I'm from International Nursing Program. My question is, in Indonesia, you say before, in Kalimantan or Papua have many village. And then how nurse do to develop palliative care in the village? Because not all village in Indonesia have adequate hospital or clinic, sir. Thank you.
This is a very important situation that you addressed. The palliative care, especially home-based palliative care, and this is something that you really need to organize. As a nurse, you have a specific responsibility to be the connection between the patient and the family and the physician. So if you can report your observation, your clinical observation, the patient is doing well, then you can report to the physician, the patient is not doing well. I have the impression we need to change the treatment. Then you can involve the physician. You can use level D hospital. So you should have a partner over there to whom you can call. Just ask them, this is my situation, what can I do to do a better job? So this communication exchange between nurses, especially in a rural situation, and a specialist who is available and responsible for the region. This is something that Indonesia really needs to develop. I know that you are doing it and you're trying to roll out, but still there is something to do. And telemedicine, so this is a good question. Telemedicine can support you. So if you have a kind of structured reporting, this can assist you in doing a good job. And then you can provide better care in a rural area, in a remote area, to the patients, because you have a background. You have a physician in your background who can assist you in making the right decisions.
The next question. Okay.
Thank you. Introduce myself. My name is Muhammad Iqsal Rumalean. From the data I got, the rate of breast cancer in Germany is slightly lower compared to Indonesia. My question is whether there is a special program used by the German government in dealing with breast cancer, and are the certain methods used in treating breast cancer patients in Germany? Thank you.
Before I answer your question, I have to explain a little bit the numbers. The cancer incidence is very much related to the demography of the population. So the cancer incidence in a population where 50% of the population are, I think, below 30, in our population, 50% of the population is above 50. So we have a different population, and since breast cancer, it's starting early, but it's still a cancer of age. So it's a little bit difficult to compare. So if you analyze these incidence data, always ask what is the population behind it. So this is just one additional comment. So breast cancer care, we start with a screening program. And this screening program is organized since about, I think, 10 years or something like this. It's organized by invitation. So all eligible women will get an invitation from the insurance every 3 years. And every 3 years, they can go to the screening units, and then they will get a mammography for early detection. In breast cancer, we don't have primary prevention, so we cannot, there's no vaccination, so we do early detection. It's so-called secondary prevention. And this affects not the incidence, but the stage. So we can detect breast cancer at earlier stages. And during the last, we saw a shift in the cancer cases. So advanced cancer, breast cancer is actually a rare disease now. And most cancer cases have early stages, so they can be treated in a better way. And always, cancer is treated as a combination, surgery, chemotherapy, radiotherapy, especially in breast cancer. All of these modalities are used in combination depending on the stage. If you have lymph node involvement, how large is the primary tumor, and these things. So this is a decision that the tumor boards are making. So they discuss all the situations. They look at the patient. They look, what is the age? Do we have comorbidities? So all the specialists together, they discuss what is the best way of treating the patient.
Thank you, sir.
The next question. Yuk. Siapa yang mau nanya? Yang sebelah sini belum ada nih yang nanya tadi. Yuk. Okay, good.
Assalamualaikum warahmatullahi wabarakatuh. Introduce my name Rika. Thank you for allowing me to learn, and in advance, I want to apologize for my bad English. Well, my question is related to the professor view on what are the obstacle or problem in Indonesia that cause health management in dealing with cancer patient to be inferior to other countries. According to Prof, what makes Indonesian health management problem less to be the choice of cancer patient of other palliative disease? As we know, a lot of Indonesian people themselves will prefer to seek treatment abroad while starting from professional health worker. Health tools in large hospital are constantly updated, even to the information of them to go directly to the community to improve the quality of health service. But still, Indonesian health management cannot be equated with the ridicule of the countries such as Singapore, German, and US, United States. And the second question, according to Prof, what we can as prospective health worker do to change health management so that it can better again. Okay, thank you.
I did not understand everything. I'm very sorry. Can you ask a question in a very short way? Maybe it's easier for me.
Bahasa Indonesianya boleh. Oke. Menurut Profesor, apa yang menjadi masalah manajemen kesehatan Indonesia kurang untuk menjadi pilihan pasien kanker atau pasien penyakit paliatif lainnya? Seperti yang kita ketahui, banyak sekali masyarakat Indonesia sendiri yang lebih memilih untuk
This was the reason actually that I spent some of my time to acceptance. I know this phenomenon, of course, and this is actually very typical for low and middle income countries. So that the people that can afford it are going abroad. So this is not unique to Indonesia. I'm also working a lot with Armenia, which is a very small country, but the economic situation is very comparable. And so what could you do? The first thing is to organize the system that it is better accepted by the patients. So if it has to do not only with quality of care. Of course, some treatment is not available here. For cancer, for example, radio oncology, you have only very few units in Indonesia. And so radio oncology, of course, if they can afford it, they will go abroad. So, but the majority of the patients should accept the quality that they can get here in your country. And that's why I'm talking about the management issues. So if they have effective way of getting access to the treatment, if they have effective way of getting support, for example, at home. So if you are going to Singapore, home-based treatment is difficult. The organization of the entire, it's called the chain of delivery. So all the interactions between the different professions, between the different specialties, between the different levels of hospitals. If this is improved, the acceptance of the population for the treatment at home is getting higher. This is not something that you achieve for next year. This is a long-term process. But building trust in your own system, this is actually your task, because, and I repeat what I have said, if you educate the patients how to behave, how to take the system that you have, what is the best way to use the system, then you will participate in trust building, step by step, small steps. But trust building is actually the responsibility of the key players in the system. And the key players, this is you. So if you can build up trust, then step by step, just forget the very rich ones. They will go anyway. The public perspective is that you treat 90% of the patients here, and they have to be trustful in the system, and they have to deserve the best quality that you can get. And maybe step by step, some of the richer ones will also, yeah, okay, at home, there's something, this is okay for me, I can use it home-based, not in the next 2 years. But in the long run, step by step, you can improve, and then they will come back.
Okay, thank you, Mr.
Finally, we get to the last session in this event, which is closing. Let us close the event by saying Hamdalah. Alhamdulillah. Next, let me present appreciation certificate to Professor Dr. M.A.D. York Hire, LLM, Kit, for sharing this valuable knowledge as a guest lecture to nursing student of Aisyah University of Yogyakarta. To Mrs. Armenia, Sarjana Keperawatan, Magister Keperawatan, please to come the stage.
Terima kasih.
Cek. Ya, untuk teman-teman sekalian, untuk selanjutnya kita foto bersama ya. Silahkan untuk teman-teman bisa menghadap ke bagian selatan yuk. Segera yuk. Selatan tuh sana. Sudah berapa tahun? Ayo. Sini berdiri, berdiri. Ayo berdiri. Berdiri kemudian segera ke bagian utara sini. Bagian bawah jamnya di depan sini. Yuk, yuk sini mahasiswanya sini. Teman-teman silakan. Hah? Oh. Nah, nek di sana. Ya. Ya teman-teman ya. Ya walaupun nggak kelihatan banget tapi ya yang penting ada ya. Yuk, merapat yuk. Ayo. Oke, karena mahasiswanya terlalu banyak, kita buat beberapa sesi ya. Oke. Minta izin beberapa sesi nggak apa-apa ya? Ya, Feb, tolong Feb. Ya teman-teman yang di depan sini bisa agak minggir sebentar. Oke, presensinya nanti. Ayo. Geser dikit. Oke, kelihatan semua Feb? Oke. Kelihatan semua Feb? Oke, yuk. Formal dulu ya. Formal dulu. 1, 2. Yuk ganti gaya. Freestyle. Oke. Satu lagi. Oke. Sesi pertama bisa gantian dengan sesi berikutnya ya. Yuk. Biar teman-teman kelihatan yuk. Ayo. Arman, come on. Ayo. Cepat yuk. Ayo nggak apa-apa. Ayo, itu gelombang doanya cuma dikit banget. Ayo mas. Ayo. Biar cepat pulang yuk. Ayo. Nggak apa-apa, ayo. Ayo. Oke. Yuk, sesi 2 yuk. 1, 2. Yuk. Lagi. Freestyle ya, kayak bebas ya. Yuk. 1, 2. Sudah, Beb? Oke. Thank you. Prof. Dari